Good evening and welcome. I'm Jean Johnson, a librarian at Stanford Health Library. Thank you for joining us at tonight's talk, From Trauma to Resilience, Effective Interventions for Youth. It is my pleasure to introduce our speaker tonight, Victor Carrión. Dr. Carrión is the John A. Turner Professor and Vice Chair of Psychiatry and Behavioral Sciences at Stanford University and Director of the Stanford Early Life Stress and Resilience Program. Dr. Carrión is also faculty at both Stanford University School of Medicine and Lucile Packard Children's Hospital. His multidisciplinary research on the behavioral, academic, emotional, and biological late effects of trauma has led to the development and implementation of new effective interventions for children who experience traumatic stress. Throughout the program, please enter any questions in the Q&A box at the bottom of your screen. And at the end of the talk, Dr. Carrión will answer as many as time allows. Doctor, I'll turn it over to you.
Thank you, Jean, and thank you to the library for this very nice invitation to join you tonight, and thank you for all of you that are joining the Zoom. I am going to share my slides. Before we begin, I want to say that as we're meeting here tonight, many of our friends, many of our family are struggling with the ongoing devastation in Los Angeles. Another painful reminder of the frequency of trauma in our lives, in this instance, a natural disaster. Today, we will talk about natural disasters and man-made disasters, and the accumulation of both of these, which we call the allostatic load. In my team, we call it the backpack that we all carry of all the experiences, good and bad, and in between, that we all have. But what happens when you're very young and you start with your backpack getting full and getting heavy? That will be part of what we are going to be discussing today. Okay, so the battle between nature and nurture is pretty much over. We really know that both genes and environment interact to really impact our stress vulnerability, and that will be different for different individuals. For some individuals, that will bring, as we all have heard by now, a syndrome that we call post-traumatic stress disorder. Sometimes people call it post-traumatic stress injury because it's something that really can happen to anyone with the right amount of allostatic load, or anything else, really, anything else that we may be at risk for, like anxiety, like depression. But another outcome is also resilience. And we will talk today not only about the sequela of stress and environmental trauma, but in terms of pathology, but also in terms of getting us to be stronger and getting us to tolerate that stress. So how do we make those differentiations? Well, not all stress is bad. In fact, we all need stress to develop, and we need stress to develop skills and develop coping abilities and develop a whole armamentarium of ways to adapt. In fact, according to this curve here, which is an inverted U-shaped curve, if we don't have any stress, we may not do as well, right? If we don't care about that exam that we're going to have tomorrow, we probably won't do that well. So the more stress we have, the better we perform, but only up to an optimal point, only up to that area of optimal stress. After that, what we see is that with more ongoing stress, our performance, our happiness, our health begin to decline. And it is in this second part of the curve where we actually find the syndromes that I was talking about, such as PTSD as a consequence of post-traumatic stress disorder. I want to talk about, present a case to you so that you have an idea of what we talk about when we talk about interpersonal trauma. So there's natural disasters, as we all know. Then there is interpersonal trauma, which some examples are sexual violence, physical abuse, witnessing violence. And I want to show you the progression of Sammy as we talk about one of the treatments that we have developed here at Stanford, the Q Center therapy treatment. So Sammy is a sixth grader, right? And mom has noticed that he's not behaving the way that he used to. In fact, he's becoming aggressive and he's hitting his brothers. And this was not something that Sammy used to do, very uncharacteristic of him. She herself was feeling guilty, she was feeling confused, and she reported to the authorities that Sammy's father had regularly abused her and the children physically and emotionally for a number of years. Sammy, in particular, had been hit numerous times with metal bars, wooden rods, bamboo sticks, and Sammy's mother felt the boy's behavior was directed at her for breaking the family up because mom actually, when she brought this up, the dad was arrested and he was deported. Sammy had nightmares and difficulty sleeping, and he scored in the moderate level of post-traumatic stress disorder. So we will talk about Sammy in a little bit. But before that, let me talk about how do we know, right? How do we know that Sammy is responding to his experiences versus having any other condition? Well, the history is a big part of this. The person was exposed to something that threatened their physical integrity, usually death, something like threatened death, or threat to serious injury or sexual violence. And this was through direct exposure or through witnessing in person or indirectly witnessing it to another person, a relative or a friend. And then what happens is that as a consequence of that, if any of us experience this type of experiences, we are going to have a reaction to that. But in individuals that develop post-traumatic stress disorder, this reaction continues after a month. And some of the symptoms that you see are very intrusive. These are the nightmares, like in Sammy's case, dissociative reactions, really having difficulty perceiving what's real and what is not real, an involuntary, intrusive memory. Sometimes we see this in terms of play in youth, what we call traumatic play. Play is very important during development. It's how we develop socially, emotionally, physically. And when trauma occurs, it robs the kids of play because play becomes a means to tell the narrative of what happened. Because children sometimes don't have the vocabulary or don't really understand the context. And that traumatic play, although sometimes we can use it clinically to find out more about what happened, it really impacts the child in their own development as the play is not existent, the developmental play that they should be having. Also, there's marked physiological reactivity in many of these kids. This is an example of traumatic play. It looks like a drawing, but when you look at these faces, there's really no enjoyment in these children. In fact, there's horror, and this is a child that was exposed to war. And here we see a picture of a very social girl that on clinical examination was doing very well. But when you gave her an opportunity with a piece of paper and a crayon, she really needed to narrate how she and her sister were the only ones that survived this earthquake in Haiti. and they were the sole survivors, and they were found in the rubbles by a neighbor. So she is basically telling this story with this picture. And those are symptoms of intrusion, right? The trauma still needs to be processed. Another group of symptoms are symptoms of avoidance. And in my team, we have a saying, which is PTSD feeds on avoidance. Because to pretend that something didn't happen or to deny it really doesn't allow the individual to process the event and really encapsulate it and include it in the narrative of their life. So this is a persistent, effortful attempt to really not have any of the stimuli associated with the trauma in their lives. So this constricts their life further. Sometimes it leads them to not engage socially with some or many individuals or in some or many places. And then there are symptoms of negative alterations in cognitions and mood. So in the past, many of these kids were thought to also have depression. And what we really have realized is that many of these symptoms of depression really didn't constitute a separate diagnosis. They were part of this negativity that sometimes happens after trauma. Negative related emotions, feeling alienated, having an affect that is constricted, diminished interest in things in life. And then there's this physiological arousability and reactivity. And this leads many of these children to receive the wrong diagnosis. Many of these kids sometimes get diagnosed with having attention deficit hyperactivity disorder. That hyperactivity is misunderstood. The hypervigilance is misunderstood as hyperactivity. What we have here is hypervigilance, exaggerated startle response, sleep difficulties, and we see that also as symptoms. So as I mentioned before, if these symptoms exist for more than 1 month, if they really affect the life of the individual, right? In terms of how they relate to others, how they relate to family, in terms of how they're doing in school, as we saw in the case with Sammy, then it has a functional impact. And then there's all kinds of different ways of characterizing it. But then at that point, we call it post-traumatic stress disorder. So what happens when the kid is filling out this backpack with all of these experiences, and they may have subthreshold symptoms, or they may have all the symptoms that I've talked about, but at the same time, their little brain is developing, right? 100 billion neurons are trying to find the right place, the right synapses, the right pruning, the right myelination. You would think that many things can happen, and unfortunately, not a lot of bad things happen, but some of the things that happen, we were interested in finding out biological markers of stress and trauma beyond a behavioral description of PTSD. And the reason for this is because of that difficulty that sometimes a behavioral definition has in how we classify or how we diagnose or how do we clinically assess a child, right? Thinking that they have ADHD, for example. And let me clarify that ADHD certainly is a condition and it exists. And certainly kids that have ADHD can have exposure to trauma and develop PTSD. So you can have comorbidity of both conditions. And then the clinical scenario becomes even more complicated and more confusing. But it's very important to know what is what so that you give the right diagnosis. The intervention for ADHD is pharmacological. The intervention for PTSD is really psychosocial. It's a psychosocial intervention therapy, in other words. So we know that when we are stressed, we release a hormone that is called cortisol. But we also know from animal research by Robert Sapolsky, Bruce McEwen, and others that cortisol can be neurotoxic. And being that there's so much going on in the brain during development, we were very curious about how cortisol was having an impact on this. So one of the first things that we did was to see very early in 2002 to see what the levels of cortisol were like in children. Cortisol gets secreted by the adrenal glands, which sit on top of the kidneys, as is illustrated here, with messages that come from the brain into the body, and this axis regulates itself by letting the body know when they have enough cortisol or they don't have enough. And it's very helpful. If we're going to cross the street and we see a big truck coming, we jump out of there. Part of what helps us become aroused and get out of that situation is that release of cortisol and adrenaline and others. But what if you're 5, 6, 7 and you feel like a truck is coming at you every day, right? What happens to this axis? Does it desensitize? Well, in some instances, it might. So we started looking at cortisol in youth, as I mentioned very early on, and there's a normal circadian rhythmicity for cortisol, meaning it is high at the beginning of the day, and as the day progresses, it goes very low so that you can actually go and fall asleep. In what we found was that the PTSD group really had elevated levels throughout the day, even though it had that circadian rhythmicity. And it was significantly higher pre-bedtime, as I will illustrate. But then, as we got more samples, as we studied this further, that pre-bedtime level became like a marker of really having pediatric PTSD. It was high levels of cortisol. And the question then is, well, do you need to have high levels of cortisol when you are struggling with these experiences and with these symptoms? And or not? And is it high all the time? Or does it auto-regulate? Well, what we found is that for the first year to 2 years of having the heavy backpack, this really held, having high levels of cortisol. But later on, we start seeing the picture that sometimes we see in adults where the cortisol is actually lower than it needs to be. So the system kind of desensitizes, stops functioning the way that it should. But if cortisol is neurotoxic, what impact do these high levels of cortisol have during these key developmental stages early in development? And specifically, what impact does it have on areas of the brain that, like we see here, that are sensitive to cortisol because they have cortisol receptors? Areas like the amygdala, the emotional core of the brain, the hippocampus, where we process memories, the prefrontal cortex, which helps us with executive function, attention, concentration, all of this. And what we see is that these subcortical areas, the parts that are not prefrontal cortex, we call that the limbic system. And sometimes this amygdala in PTSD can be hyperactivated. And the prefrontal cortex works almost like a brake in controlling that emotion of that amygdala. By the way, some connections between the amygdala and the hippocampus are very short, sometimes only one neuron. So that's why some memories give us emotions and some emotions bring us memories and things like that. But this limbic area of the brain, which is also known the reptile brain, because we've had it there for a long time, is sensitive to the impact of cortisol. And what we see is that it's not only the way that I described it, that is prefrontal cortex control over the limbic system, but there are also pathways from the limbic system to the prefrontal cortex. So the system is more dynamic. What is important in this slide as well, besides the brain, is the actual child and the actual senses that we can see in this picture. The eyesight, the smell, the taste, the skin to touch. And the senses are really the window to the central nervous system. And as I describe triggers and cues and reminders, I want you all to think about senses, because these senses, we have utilized them to actually help us heal the potential damage that trauma can cause. And this will become more clear as I talk about cue-centered therapy. Cue spelled C-U-E. Okay. So we wanted to see if there was a relationship between these cortisol levels and how the brain was functioning. And we started using MRI. And with MRI, we see that the pictures of the hippocampus, when we just look at a picture structurally, look the same, which it was great. But when we did functional MRI to see how much activity there was in those hippocampus, we found that the kids that didn't have a history of trauma and PTSD symptoms had significantly more activity in the hippocampus than those kids that did have the PTSD. And the yellow here indicates that increase activity. And this is in MRI images, we talk about voxels, the units of measure of the picture. And we can see the activation being higher in the controls than in the group that has PTSD symptoms. So what's the relationship with, that was the limbic side, right? The hippocampus. What's the relationship with the prefrontal cortex? Because they also have glucocorticoid or cortisol receptors. Well, we find there also that there was a relationship, a negative association, that the more cortisol you have, the lower volume in areas of the prefrontal cortex, meaning that that brake may actually not be working that efficiently. And in fact, when we look at task of executive function, investigating more what's going on in the prefrontal cortex, and we take images of the control group and superimpose them over MRI images of the group that has PTSD, we see that the activation of the frontal lobe of the control group is higher. When we do the opposite and we put the pictures of the PTSD over the control, we see an area that is really not even supposed to be involved in the task that is given here during this functional MRI. This is the medial prefrontal cortex. And what we're seeing there is probably the association between anxiety and PTSD symptoms. We also did a separation here between children that have a history of self-injurious behaviors and children that did not. And there's an area in our temporal lobe called the insula, because it's very insulated, it's very inside the temporal lobe, that gets more activated in those kids that engage in self-injurious behaviors. And in fact, we have published that the more activity that you see in the insula, the higher the score of PTSD symptoms. In the amygdala, we see a positive association between age and amygdala volume. So the size of it also seems to change in that it gets bigger when compared to controls. But in younger groups, we see a smaller amygdala than in controls. So the amygdala, it really is not developing appropriately either. Another way of investigating the amygdala is by giving a different task in fMRI, one that shows emotional phases, and examine the amygdala as these emotional reactions are occurring. So when we present angry faces, we can see right away that the red line, the group that has PTSD, activates the amygdala immediately. And this is basically a biological marker of what we were talking about earlier in terms of hypervigilance, right? In terms of that physiological high response, and also a hint that maybe the prefrontal cortex has a break, is not doing its job. So when we show other faces, this time fearful faces, we can see that there is diminished prefrontal cortex activation in the PTSD group. So it's not only regional by region, right? Like we were examining before, cortisol affecting limbic and prefrontal, but the networks themselves, the communication themselves is being affected. So we've always known that risk for PTSD has to do with proximity, with dose, which is an interesting thing because with social media, with TV, with everything, the proximity becomes very high for many youth of things that happen, miles away. So we've all known about proximity, we know about family history, we know about previous trauma, but now we're really including levels of cortisol, early amygdala reactivity, diminished prefrontal cortex activity. So all this sounds like bad news, right? All of this sounds like trauma really has an impact in the brain as the brain is developing. But what I want you to realize that what we also learn is that there is an impact of environment in biology without putting any balance on it, right? So if in the trauma case that is negative, what would happen if that environment is positive, as in a good therapy experience or a corrective emotional experience or a good mentor or a good experience with a sport, right? What happens with these positive experiences, and do they do the opposite? Well, we decided to explore that. And the good news here is that these areas that I've been talking about, the cortical areas and the limbic areas, yes, they're very complex. There's a lot of networks back and forth, but the more complex areas are also the ones that have more neuroplasticity. So our ability to really mold them in a positive way and maybe repair some of the damage or protect them from damage that may occur otherwise. So we attempted to do that in a psychosocial way by developing a treatment that's a hybrid of many interventions that we know work. Interventions that look at family systems, as the developing of self-esteem, at creating a narrative, at exposure, at gaining insight. We combine all of these things in a short-term psychosocial intervention that we call Q-center therapy from 15 to 18 sessions. We wanted it to be flexible in that the characteristics of the child and the characteristics of the therapist are very important, and we wanted to take that into account. And we wanted to address 4 core domains: what the kid is thinking, what the kid is doing, how the kid is feeling emotionally, and how the kid is feeling physically. And different personalities of kids will attach to the therapist and the treatment through one of these situations, either because of the way they feel or because of what they do or because of the way they're thinking. So different personalities doing differently, but ultimately what we want is this square, these 4 points to be addressed. And for them to enter it one way is totally fine. The sessions are very straightforward. We start with education. Before we get into the narrative, creating the story of what has happened, we really want to make sure that the kid has the coping abilities to handle the emotional work that entails. So we engage time in teaching them mindfulness, relaxation, and cognitive tools, and also in helping them develop their own, which can be quite powerful and serve to the purpose of self-efficacy and empowerment. After all, this treatment is about the kids being the agents of their own change. So really, they themselves being their main tool throughout life. And then we get into this, not a story of what happened, right? The fire or the shooting or the physical abuse, but all of it. What happened before, what happened during, what happened after. And we call this the chronic traumatic stress history. And And here, the therapist is like a journalist, it's just getting facts. And then after that, they can really help the child process these events and correct maybe cognitive distortions, things like, I made it happen, right? Kids can be very egocentric in a way. Developmentally, that's very good because they need to make sure that they grow and that they're okay. But what happens is that if something bad happens, they start thinking that maybe they had a role in that. So we want to correct that cognitive distortion. And then we do an update with the parents, and then we start talking about cues, these triggers, these reminders that are very important because are the ones that sometimes are avoided. And we don't need to identify all cues, but if we can identify two, three, five that we can work with and then have some exposure, some gradual exposure, then this would be very helpful. And CCT is really more about the how than the what. So I presented the what, very straightforward, but the how is really the development of the relationship and the development of the child as his or her own agent of change through self-efficacy and empowerment. They identify the cues. They start making links with their responses. The responses are the square that has those four areas that I talk about, the cognition, the physiology, how they feel, what they do, all of that. So we tested it, right? First with a waitlist group, and then we saw that it works. It decreases PTSD symptoms when we assess the child, and also when we assess the parents, we see that it decreases symptoms on the child. It decreases symptoms of anxiety, and interestingly, the more it progresses, the more it decreases, which is a good thing. But I like to show this picture because I want you to see the very important slope that happens early in treatment. And what we're doing there is really psychoeducation and teaching coping skills. So even before we get to all the other work, sometimes just learning what's going on. Why am I reacting this way? Learning that other people react this way, that any of us could develop this type of symptoms is very helpful on itself. So how do we translate this treatment to the experience of Sammy? So as you remember, Sammy had been hit and had more aggression and nightmares and all of that. But with CCT, the education into his symptoms enabled mom to manage Sammy's nighttime episodes. And Sammy found relaxation exercises gave him a sense of control, a sense of calmness, and then that allowed for work with the narrative. Now, not every kid is going to find relaxation to be helpful. In fact, for some kids, relaxation itself may be a cue. So this speaks to the importance of this personalized approach to how you treat these children. But for Sammy, he felt safer, but he had discordant feelings. He felt safer, but he also missed his father. I mean, he reminded me not every time with my father was bad. Sometimes we would go to the park. Sometimes we would have ice cream, and that is not happening now. So he needed to really process how, as individuals, we can have discordant feelings, and that didn't make him weird or anything like that. He started connecting how he was reacting physiologically with increased heart rate and processing the feelings that he would feel of guilt and shame after the aggressive episodes towards his siblings because it wasn't him, right? So there was guilt associated with this. And guilt itself is a very good predictor of PTSD itself, which reminds us that the mother had some guilt as well, right? So sometimes you have to work with the whole family when you're treating these cases. Sammy and his mother were introduced to this concept of traumatic cues. His father's violence was explored as a fearful event. We underscore that cues are really neutral. They're not good or bad. They are a color or the time of day or the rain, something that happened, right, during the traumatic event that our brain associated with some negative result. That's called classical conditioning. So we actually literally teach them classical conditioning. And Sammy were taught how responses, what we do, are characterized by these four corners. of behavior, emotion, physical feelings, and thought. We concentrated on not getting rid of the aggression, but on developing competitive responses. Because many times, if you try to get, if you just concentrate in stopping the behavior they're doing, what you're doing is asking the kid to give you the only tool they have. So what we want is for them to have an armamentarium so that then they can drop the ones that are getting them in trouble. Although impossible to identify all pertinent cues, our ability to address some cues helps Sammy make a connection between history and behavior, what happened and what he's doing, right? So their kids many times compartmentalize and they know that they behave a certain way because something happened and they were having some feelings, but they don't know that all of that, the history, the feelings, and the behaviors are really connected. So we have ways of making that very clear to them, and then having exposure and developing new responses that are more adaptive. And then by graduation, Sammy was doing better at school, not arguing with his mother, not hitting his siblings, and feeling better about his accomplishments, and didn't have clinical PTSD any longer. So we did that weight trial. Then another thing that we did is that we did something called functional infrared spectroscopy, where we can actually look at cortical areas of the brain and see the blood flow. And as kids improve, we were seeing that kids' blood flow to the prefrontal cortex was also increasing with this treatment, which is a very good thing. But that's for kids that have PTSD. What happens when they're at risk? Can we do something to actually prevent it? We did a study in all of East Palo Alto in the whole school district where we implemented yoga and mindfulness to the schools, to the students via the teachers. We would train the teachers and the teachers would take it to the classrooms. And there's a number of reasons why we use yoga and mindfulness. First, there is a literature that it is very helpful. We also had the personal experience of our own team, of us using it and how it was helping us. And we had some pilot data of how it was helping some classrooms. So we did it in the whole school district, and we had a control group. We had another school district that was not receiving the intervention. Eventually, they did after the study was over, but they serve as the comparison group. One of the things that we did and we wanted to do was to look at the biology of what was happening in the kids that were in the intervention group and receiving the yoga and mindfulness versus the kids that were in the comparison group. And it's not too clear here to see, but if you see the white and the gray, not the blues, but the white and the gray, those are the intervention groups. And you can see a drop before and after the intervention, the yoga and the mindfulness in terms of amygdala reactivity. So one of our findings is the amygdala seems to react less when you're doing yoga and mindfulness. But something that was also very important is I mentioned that there's this high cortisol levels at night. And there are a lot of symptoms at nighttime, and one of them includes really very poor sleep. Now, the kids that were in yoga and mindfulness, the intervention increased their sleep by 73 minutes. So their total sleep increased. So the quantity was good, but the quality was also good. The deep sleep also increased. REM increased in youth that receive the intervention. So we have now a treatment, we have now a prevention method, and we know a lot about the impact of trauma and psychosocial intervention to heal from trauma. But what about resilience? And what about how to build resilience for even before trauma occurs or trauma happens? Well, in the department, we have a number of investigators that work with what we call organoids. Organoids are stem cell derived, they can be any type of cells, but in this case, neurons that grow suspended and connect to each other. and they become functional. They actually work like neurons that communicate with each other. And in this collaboration with Alex Urban, one of our investigators doing this, and we actually expose some of these organoids to cortisol. And what we saw is that some genes actually became identified as areas of interest in terms of how they were reacting to the cortisol. So some of the genes that were identified that were involved in this process, depending if they were more affected or less affected than other organoids that were exposed to different levels, there was a gene differentiation, and some of these genes have been published in the literature as being related to PTSD. But we also found some genes that are actually related to the aging process, collagen formation. Accelerated aging is something that is of high interest to us because sometimes we see these kids acting older than they should. But not only that, in mental health in general, individuals with serious mental illness tend to really die younger than individuals that do not have serious mental illness if they are not being treated. And issues like atherosclerosis, dementia, and other issues may be occurring with more frequency in untreated mental illness. And this accelerated aging may have to do with a backpack that goes unchecked. So, not knowing a lot about resilience, we want to know more about it. And we want to know more about the genes that are involved. And here we have some hints. But when you have some hints, what you do is that you really have to do a population study. And that's what we are now starting to do in Puerto Rico. In fact, we have conducted a pilot there as well. So I talked about East Palo Alto, a school district, right? Now we are going to one of the largest school districts in the US. The whole island of Puerto Rico is one school district. And there's a number of reasons why to do this in Puerto Rico. Puerto Rico has experienced a number of traumatic events, both natural disasters, sociopolitical, that really has impacted the Department of Education in the island. So we are engaging with schools. We've done a pilot with 3 schools, taking them through the process that I'm going to describe, which is basically that all kids are taught this yoga and mindfulness through the teachers, right, that have been trained. Then we screen kids for signs of and symptoms of PTSD. And then they work with the counselors that we have trained in the Q Center therapy. While doing this and while conducting assessments in the teachers, in the counselors, and in the students, we're also collecting vocal swabs from the students so that we can have epithelial cells and study any epigenetic changes that relate to responding to treatment and to developing resilience. And resilience is one of the measures that we assess as we move further. So we look for signs of burnout and competency and resilience and stress in teachers. Similarly, we do that with the counselors as well before and after they give the Q Center therapy. And then with the students, we look at things like anxiety and depression, which are highly comorbid with PTSD, but also, as I mentioned, resilience and then cells that can help us study with our collaborator, Alex Urban, this epigenetic analysis. So that's where we are. I want to thank the supporters of this work, the Lucile Packard Children's Hospital Foundation for Children's Health, the Evans Foundation, NIH, NARSAD, Medical Foundation for Suicide Prevention, the American Academy of Child and Adolescent Psychiatry, and of course, no one does this work alone. I want to thank my terrific team, the Early Life Stress and Resilience Program, and I want to thank all of you for being here today.
Well, thank you, Doctor, for sharing this really important information. And thanks to our audience for joining us and for some questions, great questions. The first question I want to talk about, and you kind of touched on it with the Puerto Rico information, can some of these treatment interventions be applied to adults?
Yes, so we have a training program for Q center therapy, for example. And many of the individuals of the therapists that have trained in that program have told us that they use the same methods with adults with good results. The manual, which is published by Oxford to train trainers in Q center therapy, is very child-oriented. So we're thinking that it really needs to be adapted so that it is adults feel more comfortable with the material, but the essence of the material would be very similar, would be the same. By the same token, we are thinking of adapting, we're in the process of adapting the treatment to preschoolers. And their more developmental differences, have to be made. So we're exploring those as well.
Thank you.
And also let me say, so that's for CCT. For the yoga and mindfulness, we train the teachers, but the objectives are double. It's not only so that they teach the students, it's so that they also benefit from the lessons they're learning in yoga and mindfulness. This is a curriculum that we call Pure Power, and it's developed in part it was developed by us and our partners at pureedgeinc.org. And I'm giving that link because they have a number of very significant resources on their website that they call brain breaks that everyone can access. And they're very helpful.
Great. What do you think we should be focusing on more, or what is your center focusing on more, trauma prevention or sort of the resilience therapy?
Yeah, I think we have to pay attention to all of it because I mentioned the fires at the beginning of the talk, and the reality is I've been in this field for probably more than 30 years now, and there has always been man-made disasters and natural disasters. But the frequency at which I see it occurring in the last 8 to 10 years, it's considerably higher, including wars right now, having two wars that have gone for way too long, affecting way too many lives. So we need to address the trauma, right? And then, but on the other hand, we know very little about resilience. So there is a lot of work that needs to be done on resilience. We know a few things, and most of them are behavioral. We know that having a good IQ is helpful. We know that having a sense of humor is helpful. We know that being perseverant is helpful. And we also know that having an adult in a child's life that helps them process experiences, that give them opportunities, that can listen to them is very helpful. And it doesn't matter who that person is. It can be a caregiver, it can be a coach, it can be an aunt, the presence of someone. But what if it's not the presence of the individual only, but is also what's in the child that makes them seek that type of relationship and of maintaining it? So these are important resilient factors that remain to be tapped, remain to be identified. And that's one of the things that we are after in this study in Puerto Rico.
Oh, thank you. Someone was also wondering if the topic of intersectionality affected the findings in your research.
Most definitely, and I would volunteer not only my research but everyone's research really, because in studies we need to be very concrete and we need to be very clear about what our population is. And we talk about a Latino population, or we talk about a gay population, or we talk about, a Puerto Rico population. But what if you are gay and Latino, right? How does that impact the findings? And I think something that we're doing that is very good here at Stanford is that we're really concentrating on a personalized approach. What is it that you're bringing with your intersectionality? What is your history? And that history is very much of that one individual, and it's going to have an impact not only on the experience that they've had on their backpack, but it's going to have an impact on the resources that they need, or the treatment that they need, or the help that they need. Very much in the same way as if it was a type of cancer or a problem with the heart, right? That we actually are getting away from treating diagnosis, right? So we don't treat PTSD, we treat the individuals. But not all the individuals are going to be the same.
The next question actually kind of goes back to the previous, before this last one. Should this, I think, the interventions you're doing in Puerto Rico, be applied in public schools to all children, as some may have PTSD that has not yet been identified?
Yeah, I don't think that CCT should be given to kids that we don't know if they have PTSD symptoms or not. I think certainly there are components of it, like learning cognitive skills and having psychoeducation, that can be very helpful. So my question is half yes, half no, because those components would be very important to teach them in health class or homeroom class or something like that. And in fact, that's part of what we're doing with the yoga and mindfulness curriculum. The yoga and mindfulness curriculum also includes a lot of psychoeducation into the nervous system, not so much into pathology, but into the brain and how the autonomic nervous system works.
Okay. The next question, someone asks if you're familiar with the works of Dr. Gabor Mate.
I think his work focuses on insight, really having people understand why they do things. So it's very dynamic in that way. But that's to the extent that I know. Yeah. Yeah. Having insight, which we also call psychodynamic psychotherapy, is very important, because when I was talking about kids compartmentalizing a lot, what happens is that they know that something happened. They know that they have some feelings, usually fear, sadness, anger, and then they know that they're doing some behaviors that are getting them in trouble. But they don't see the connection between those three. So that process of, oh, because that happened, I developed these feelings that make me do that. That whole process, that's insight. So that's something that sometimes we achieve in more complex scenarios through psychodynamic psychotherapy. So it was important for me to take components that were not solely cognitive behavioral, but that were also psychodynamic, and give them a similar structure. And that's what we do in Q center therapy.
Well, thank you very much. This has been fascinating for me, and I think for the audience. If anyone wants additional information or resources, please contact the Stanford Health Library. And we hope you will join us at our next lecture. Thank you, Doctor.
Thank you so much.
Oh, you're welcome.